with possible solids in it, I would go for a rapid sequence intubation with an ETT. With this series that I mentioned, the RAPM series, they have also published on lung ultrasound for the regional anesthesiologists and acute pain specialists. And I'm just going to give you a brief introduction. So this is basically, technically, we are looking at the lower zones. And this is what we are interested to look for. Okay, this is actually a fast view, or part of the fast view. We look at the liver and the kidney, and this is the Morrison's pouch. But can you see this? This is actually the sliding sign. This is actually the pleura moving in and out, and this is the diaphragm. So by looking at this, when you're dealing with a respiratory emergency, you know that you are not dealing with a diffusion and you're not dealing with a pneumothorax at that particular point. There's been a publication, a WIN-focused publication in 2012 by Vapucciali et al., International Evidence-Based Recommendations for Point-of-Care Lung Ultrasound. I'm just going to show you a flow of how we look, how we confirm, we rule in or rule out a pneumothorax. So we look for B lines, lung point, as well as lung pass. I'm just going to show you a video of lung point. So this is the point where at this particular white X, okay, you could see the sliding sign. So sliding sign is actually normal lung, you can see, and then there is no sliding sign. So this is actually a point where the probe is actually at this white arrow. So at a point where there is a pneumothorax, and there's also part of the lung that actually is being ventilated, or whether it's spontaneous or active or an IPPV. So if you find this somewhere a bit more posterior, you can confirm that there is actually a moderate or a big size pneumothorax. So I've actually used this to diagnose pneumothorax, and this you can do real time without even waiting for the chest X-ray to be done. There have been also documentation on the use of ultrasound to actually guide in terms of alveolar recruitment. In this particular Korean study, where they were looking at lung ultrasound in infants and how the alveolar recruitment maneuver is guided by the findings of lung ultrasound. For example, these are actually B lines, and these are actually consolidation prior to the actual alveolar recruitment done. This is actually a protocol published by Daniel Lichtenstein, the father of lung ultrasound. I won't go into detail, but technically with ultrasound, you can diagnose pulmonary edema, you can diagnose pneumonia, pneumothorax, as I showed you earlier on, pulmonary embolism, if technically if there's not much findings, and pneumonia COPD. So this is actually a purist protocol where there's no incorporation with other ultrasound examination. But I think in most point of care or perioperative ultrasound practitioners, we do also incorporate other examinations, particularly focus echo in our assessment of the lung. Okay, speaking of focus echo, this was actually the RAPM article, Focused Cardiac Ultrasound for the Regional Anesthesiologists and Pain Specialists again. Oh, I'm sorry, I forgot this was supposed to come earlier on. Okay, I know there was probably some interest with regards to COVID-19. I've just picked up some of the articles here. Not that I'm going to dwell so much in the management of COVID pneumonia, but just to highlight some of the findings. This is actually the findings by the Italian group looking at the mnemonic changes which occurs with ultrasound. And these are actually B lines which are consistent with a wet lung. These are actually subpleural consolidation. These are also consolidation. So there's actually enough, there's actually quite a bit of evidence nowadays with particularly from Europe of the use of lung ultrasound. And in some instances, lung ultrasound can replace the CT scan, particularly if patients are very unstable or on high settings, and where CT scan or bringing the patient down to CT scan room may be detrimental to the patient. Okay, with regards coming back to the focus echo, there's a 2016 publication in JACE 2014 publication by Gabriel Villa et al., which is actually, this is a wind focus group. So what they describe is actually focus echo. So when we talk about echo, basically there's a tier system. So when we send the patient for a formal echo examination, usually it will be an expert or a echocardiographer who is performing it. And then there'll be somebody, let's say an intensivist managing patients who are using echocardiography. So most likely the echo that is performed is actually an intermediate echo, or what we call an echodynamics. But what we are proposing that most acute care physicians, including anesthetists, should actually have some form of basic echocardiography, or we say focused echocardiography. So when we say focused echocardiography, we are not we are not diagnosing something which is a bit more complicated. It is something that what we want is actually to diagnose at least these 4 conditions. When you have severe hypovolemia, basically when you have hypercontractile heart chambers with small volume, or a massive PE when you have the right side dilated, or effusion with a tamponade physiology in this particular view, as well as a severe left ventricle dysfunction. If you can, the focus echo is for us to actually use and diagnose these extremes. Where it's somewhere in between, it's probably best to actually refer to an echocardiography expert. There's also been some documentation on the use of focused TE. So this is actually coming from the emergency medicine literature on the use of, instead of using 20 or 30 odd views, you only need to have 4 views to actually assist you in managing shock patients. Let's follow the protocol. One of the first few, the first description of point of care ultrasound was actually focused assessment with sonography for trauma. And it's been part and parcel of the ATLS, looking at possible bleeding, blunt or penetrating abdominal trauma. But now this is an 2019 REPM application. Anesthetists can also use FAST, for example, of course, when you have a shock patient, hypotension in PACU, when the differential diagnosis in the critically ill, as well as unique conditions, for example, nausea, vomiting, or abdominal pain following hip arthroscopy. So there's been a documentation of actually what happened in hip arthroscopy is that there is actually leakage of the arthroscope of the fluid in the joint into the abdomen, and it causes a bit of nausea and abdominal pain. And you can confirm this by actually doing a FAST examination. So what is FAST about? So there's actually a 4-view, but later on they have described an extended FAST, which technically is incorporating lung ultrasound into the 4 views. I'm just going to show you what is normal and what is abnormal. So this is normal. You can see again the Morrison's pouch between the liver and the kidney, and this is actually abnormal. Can you see the sliver of hyperechoic area here? So technically in FAST, if you have this sliver of hypoechogenicity, it is actually fluid until proven otherwise. And in case of trauma, the fluid is blood until proven otherwise. Another modality to predict hypovolemia or to diagnose hypovolemia is actually IVC sonography. I'm not going to go into great detail, but this is technically what we do. For patients who are spontaneously breathing, we expect if they are collapsible with inspiration, we can safely diagnose hypovolemia. And in patients who are on IPVP, I'm just going to bring that back. Okay, patients who are on IPPV, there's distensibility index. Anything more than 15% increase in the diameter of the IVC during IPPV, it predicts actually hypovolemia. Okay, I mentioned about in one of the earlier slides about D, which is actually disability. So with actually optic nerve sheath diameter ultrasound. When we look for this, this can also be, it is actually a surrogate, also window to the brain. So what you normally measure is actually 3 millimeters behind the optic nerve sheath or behind the globe, and you measure this optic nerve sheath diameter. In normal patients, it should not be 5.2. In some studies, say 5.4 millimeters. So I'm going to show you this particular video. So can you see that? So this is actually the optic nerve sheath. Probably not very straight to the globe. So this is what we want to see. If you have a dilated optic nerve sheath diameter, it's quite consistent with actually a raised ICP. And this has been used in various studies. For example, the one that I showed you earlier, for example, in liver pediatric patients, where you can actually diagnose possible raised ICP. Of course, in a tertiary hospital, it's probably not so important because you can easily get a CT scan done. But imagine this is quite helpful in a resource-limited environment. Okay, coming to shock protocols. So when you are dealing with shock patients, hypotensive patients with, I would say, undifferentiated shock, where you're probably not sure what is going on, you can use actually ultrasound to help you in reaching a diagnosis, and also not just diagnosis, but also in assisting you in the management of the patient. RUSH is a particular protocol that's been described. It stands for Rapid Ultrasound in Shock in the Evaluation of Critical Ill. So basically, it's rapid ultrasound in shock. So we first evaluate the pump, which is actually a focus echo looking at contractility and the heart function. We can also look at the tank. So basically looking at any sequestration of fluid, for example, in the abdomen, in the chest, particularly if there's any effusion, or also looking at the lung in the anterior part, looking for possible pneumothorax, which can contribute to the shock situation, particularly if you're dealing with tension pneumothorax. And then eventually looking at the pipes. So, for example, this position, suprasternal notch, as well as the C and D, what we're looking for is AAA, abdominal aortic aneurysm, as well as thoracic aneurysm. And the E and F is actually looking for what we call compression sonography, looking for possible DVT to the diagnosis of pulmonary embolism. There have been a few examples of few proposed protocols from ACES, the one that we were talking about, which was RUSH. So there are actually a few modalities, and we can see that different protocols would describe, they may include some components of point of care ultrasound, but some may not include. But the most, I would say, one of the most complete would be RUSH, from cardiac, IVC, FAST, aorta, lung, DVT. There have also been incidental findings for those who are practicing, vascular access, as well as ultrasound-guided regional anesthesia. It's important for us to actually realize or actually picked up abnormal findings. This is actually a case report of femoral nerve block where the practitioners actually diagnose deep vein thrombosis. This is an example of a video of a deep vein thrombosis. You could see that even the arteries are kind of compressible. You apply enough pressure, and of course, what the vein where the thrombosis sits are not occluded, are not very occludable. So it's important not to do it too much, because you might actually dislodge the thrombosis and cause pulmonary embolism itself. There have been other findings as well. For example, you can actually look for splinter. Of course, this may be probably true for emergency physicians, but in my experience, I've had actually assisted surgeons to actually look for foreign body, and instead of the surgeons wasting their time with I actually help them, particularly when we're dealing with non-metallic object. Again, these are abnormal. This is actually an abnormal nerve, a schwannoma, abnormal thyroid. This is important, particularly when we're dealing. I've actually diagnosed this when when we're doing